Happy afternoon, and I cordially welcome you all to our GarbhaGudi Institute of Reproductive Health and Research. Myself, Muthulakshmi, Academic Coordinator at GGIRHR. It's my honor to take over the platform for today's CME webinar on behalf of GGIRHR. We proudly welcome all the speakers and doctors who gathered here virtually. General instructions: mobile phones on silent. You will be on mute throughout the session and your videos will be turned off. For any queries, please drop it in the chat box. Let's begin today's CME with a brief note on the journey of GarbhaGudi. GarbhaGudi was founded in 2011, where our pioneering work has led to the progression and implementation of the latest medical technology and methods to overcome male and female infertility. GarbhaGudi IVF Center is known for its extraordinary and overwhelming success rates, ethical treatments, affordable costs, with world-class infrastructure and humane touch. Now, GarbhaGudi is spanning over a decade, who's still serving as a beacon of hope for thousands of infertile couples. Recently, GarbhaGudi IVF Center is being awarded with Bangalore's fastest growing IVF center by Radio City. GarbhaGudi ranked third for its best treatment in South India and stood 8th place across India. GarbhaGudi, which is a chain of new generations infertility treatment hospitals equipped with the state-of-art infrastructure and cutting-edge technologies like IVF, ICSI, PGD, etc., to address this ever-increasing infertility issues. Our experienced and dedicated specialists, nurses, and embryologists work to cater our couples' need and respond them quickly, as one of our GarbhaGudi way states that satisfied client is our best brand evangelist, and we aim in delivering results at higher standards. With the backing of such a capable and strong organization, GGIRHR, that is GarbhaGudi Institute of Reproductive Health and Research, is providing the preeminent training to the budding clinicians, embryologists, andrologists, and other staffs to mold them for the challenges of infertility treatment. GGIRHR is affiliated with Rajiv Gandhi University of Health Sciences for Fellowship in Reproductive Medicine, IMA-AMS, Indian Medical Association for Medical Infertility, Garden City University for Postgraduate Diploma in Clinical Embryology. We also provide ultrasound scan course and other residential and residential fellowship courses, which is GGIRHR certified. Students at GGIRHR are trained with tips and tricks, procedures and protocols followed at GarbhaGudi IVF Center, which has given unbelievable success rates. Now, we are glad to inform you all that we are spread with 7 centers across Bangalore in serving thousands of couples. Without further ado, let's begin today's CME. Our first speaker for the day is Dr. Anitha Manoj, who will be enlightening us with Polycystic Ovary Syndrome and infertility. Dr. Anitha is an infertility specialist holding decade of experience as a gynecologist. Dr. Anitha, prime motto is to ensure safe medical care for patients. She's one of the best fertility experts in Bangalore. Also, she's a member of FOGSI and IMA, Indian Medical Association. Dr. Anitha ma'am, over to you.
Thank you, Muthulakshmi, for the warm welcome. I'm Dr. Anitha Manoj, fertility specialist in GarbhaGudi. So I'll be talking about PCOS and how it affects the fertility in women. So we'll just know what is infertility. We all know what is infertility is. So infertility is nothing but couple unable to conceive even after 1 year of unprotected intercourse. So it can be for varied reasons. It can be because of the female issues, male issues, or combined issues. So it's around, the issues is contributed by 30% from the females, 30% from the male, and 30% from the combined, and 10% will be idiopathic or unexplained, where no reasons will be established or identified, but still they'll be facing the infertility issues. So what is this PCOS? So before going to the PCOS, so normally the girls will be born with some amount of ovarian follicles. It will be in millions when in the intrauterine life. When they're born, it will be in lakhs. When they enter the puberty, it will be in thousands. So every month, there will be one oocyte will be like ovulation occurs of one oocyte. So almost 400 to 500 oocytes will be ovulated during the reproductive age group of a woman on an average. So by menopause, it becomes zero, or it comes down to hundreds. So normally during the reproductive age group, that is the maximum reproductive potential will be between 20 to 30 years of a girl or a woman. So during this period, the number should be between 8 to 10 follicles per ovary. That is a normal number. If the number is more than that is more than 15 per ovary, then we call it as polycystic ovary. So it can be like number per ovary, or it can be volume more than 10 cc. Now recently we consider mainly the number. If it is associated with other things like hyperandrogenism, anovulation, or metabolic components, then it will be called as polycystic ovarian syndrome. So as a fertility specialist, this is the commonest complaint for fertility issues in the younger generation, in present generation, actually in the younger couple. So many people walk into our fertility OPD, infertility OPD with different complaints. Like there will be few people coming into our OPD saying cycles are irregular. They are able to bleed only on taking medications. That is having cycles only on withdrawal. Or few people might have regular cycles but not able to conceive even though they are trying for pregnancy for more than a year or many years. Or few people might be like obese, also overweight and irregular cycles, but they can be thin with irregular cycles, or they can be like people might come with regular cycles but still not able to conceive. The causes can be varied. The PCOD can present in a different way. It can be anovulation with the regular cycles, or anovulation with the irregular cycles, or ovulatory component will be there. That is, they might have infertility or they might have subfertility also. People might not be able to conceive, or people might conceive and might face recurrent pregnancy losses. So what is this PCOS? How it's going to affect fertility of a woman? We'll just see today's session. So this PCOS was first described by Irving Epstein and Michael Leventhal as a symptom complex associated with anovulation in 1935. So it was described long ago in 1935, though it has increased enormously in the present generation, maybe because of our lifestyle or food habits. The prevalence is around 4 to 18% in 50% of the South Asian women, and it is more prevalent in obese than the lean women. That is around 5% in thin, like lean patients, and it's around 28 to 30% in obese patients. It contributes substantially to infertility, account for 90 to 95% of the women attending infertility clinics with ovulatory cycles, with anovulatory cycles, as I already mentioned. So India has witnessed a rise in about 30% of the cases in couple of years because of our lifestyle changes and food habits basically, and stress levels also. So coming to pathophysiology of PCOS, as I already mentioned, it can be because of the weight gain, obesity, or it can be because of our lifestyle changes, pollution, stress levels, or it can be genetically also, might be running in the families. That is, genetically they are obese and they are having some metabolic factors and it's running in the family. Or it can be neuroendocrine. There is some hormonal disturbances. So that also can lead to PCOS. So abnormalities seen in 4 endocrinological active compartments, that is hypothalamo-pituitary axis. It can happen in the ovaries, adrenals, or adipose tissues. So coming to the hypothalamus, there will be increased pulse frequency of the gonadotropin releasing hormone, which increases the sensitivity, that is pituitary sensitivity, thereby increasing the pulse frequency of the LH preferentially compared to FSH. That is, there will be increase in the LH component and relatively there will be low in FSH component. So because of this, there will be positive and negative feedbacks. That is, if there is more estradiol and androgens, it can cause positive feedback and causes increase in LH. If there are, like sometimes it can be negative feedback and it can cause decrease in the LH also. But in PCOS, there will be more of LH component compared to the FSH component. So increased pulse frequency might reflect the intrinsic hypothalamic dysfunction. It can affect the abnormal feedback signals from the periphery, or it can cause both also. So this increased LH level, there might be abnormal secretory dynamics, increase in the LH pulse frequency or amplitude. So there will be more basic LH isoforms secreted, and greater bioactivity in the LH compared to the FSH. There will be decrease in FSH level, as I already mentioned. So because of the increase in GnRH pulse frequency and negative feedback effects of chronically elevated estrol concentration, that is peripheral aromatization of the increased androstenedione. This causes elevated estrone concentration. So normal or modestly increased levels of inhibin B derived from the smaller follicles. So there will be, so PCOS, this is the overlapping thing, that is increased serum LH concentration around 75%, increase in LH-FSH ratio, and low normal FSH levels. So coming to the ovary, what happens in ovary is, so because of there will be increased LH stimulation and enzyme P450C17 dysregulation also will have occur, and insulin growth like factors also there will be increase. So autocrine mediation, there will be increased insulin secretion also, and decrease in the aromatization. So all these things will affect at the ovarian level. So this causes increase in androstenedione and increase in testosterone levels. So that is why there is hyperandrogenism in PCOD patients. So there will be, this is the two-cell gonadotrophin theory. So at the level, that is granulosa cells, this decreased FSH acts at granulosa level, granulosa cells, which decreases the follicular maturation and decreases the aromatization, which in turn decreases the estradiol levels and increase in inhibin levels. The increase in LH acts at the theca cells and stroma, which increases the androgens. That is why hyperandrogenism. So LH component acts on the theca cells and FSH component acts on the granulosa cells. Since there is low FSH, there is low estradiol levels, and since there is high LH, there will be high androgen levels because of their respective actions. So excess androgens gets converted to more potent 5-alpha reduced androgens. It inhibits the aromatase activity, preventing the progressive follicular development. That is why there won't be, since there is no follicular development, there is no question of ovulation at all. That is the reason for anovulation in PCOD patients. So these granulosa cells are sensitive to FSH and insulin-like growth factors and produce estrogen, but cannot generate and maintain the estrogenic follicular milieu to achieve advanced stage of development. So there will be new follicular growth continues, but arrest happens before full maturation because of the low FSH levels. So there will be multiple small, because of this only, there will be multiple smaller follicles around 2 to 10 mm surrounded by hypoplastic theca cells, that is increased stroma, which we see in ovary during the scans, which become luteinized due to increased LH stimulation. So atretic follicles form ovarian stroma that increases in volume over time. It increasing androgen producing cellular mass, which causes anovulation. So what happens to the oocyte? Oocyte gene expression is dysregulated in PCOS. Oocyte secreted factors, OSFs, may contribute to aberrant folliculogenesis in PCOS. And there are, like, it requires of normal cytoplasmic maturation also. There are multiple factors. So in normal folliculogenesis, both GDF9 and BMP15 decrease at M1 stage, and it gets increased significantly at M2 stage. So in PCOS, this is reduced without any dynamic change. So that is why the maturation arrest. So what is the role of AMH in PCOS? That is anti-Mullerian hormone. We all know in PCOS there is excessive, I already gave an introduction, more number of follicles. And we all know AMH also will be very high. So how it's going to be high means androgen excess. That is, the increased LH is going to cause androgen excess, hyperandrogenism. This causes multiple small follicles because of the growth arrest of the follicles. And these smaller follicles are the main state for AMH. So AMH, we all know AMH gets produced from the smaller follicles. So because of multiple smaller follicles, more AMH gets produced and more AMH will be there. This in turn, there will be like FSH action, and in turn will cause anovulation, low progesterone. So this is like a vicious circle. It keeps continuing in the body. So insulin secretion abnormalities. So there will be insulin resistance also. So common feature in obese and to a lesser extent in lean PCOS, it's around 50 to 70% we can note this insulin resistance in PCOD patients. 35% have impaired glucose intolerance. Around 7 to 10% may land up in type 2 diabetes mellitus also. Even if not now, in later age, like more than 35-40, there are 6-fold high risk to develop type 2 diabetes mellitus with these PCOD patients because of the metabolic changes. These mechanisms will be described in detail in the books. So what are the effects of this hyperinsulinemia? This increases the GnRH transcription through MAPK pathway. It causes hyperandrogenism by stimulating the increased ovarian androgen production, inhibiting the hepatic serum like binding globulin production. It potentiates the action of LH. They act synergistically to stimulate the androgen production. It augments the adrenal cortex sensitivity to ACTH, stimulating the androgen synthesis and inhibition of hepatic production of insulin-like growth factors BP1. So all these are they're going hand in hand, causing the hyperandrogenism. So hirsutism, they might present with hirsutism, acne, male pattern balding, alopecia, and 60 to 80% may have high serum androgen levels. Free testosterone levels are the most sensitive indicator. Rarely, they might have increased muscle mass, deepening voice, or clitoromegaly. So these androgen circle, that is, there will be increased glucose, increased insulin secretion in pancreas, excessive androgen production in the ovarian follicles. There will be decreased SHBG levels in liver with increased free androgen levels, which in turn causes peripheral insulin resistance, and it goes on. So coming to the diagnosis. So diagnosis of PCOD, that is, there will be increased risk for infertility, DUB, endometrial cancer, obesity, type 2 diabetes mellitus, dyslipidemia, hypertension, and cardiovascular diseases. The familial implication, it is seen mainly in the first degree relatives, that is sisters and daughters. Lifelong treatments, use of insulin sensitizers are required for these patients. So coming to the evaluation of diagnostic criteria, that is NIH in 1990 and ESHRE followed by PCOS Society, and now 2012 extension of ESHRE and ASRM 2023. So NIH says the criteria was any of the two, like two of the two criteria were required for diagnosis, that is hyperandrogenism and ovulatory dysfunction, that is oligoanovulation. In ESHRE, there was like two of the three criteria, that is hyperandrogenism, ovulation, ovulatory dysfunction, or PCOM, that is PCOM in scan ultrasound picture. And in 2006, the PCOS Society says any of the two criteria, that is two of the two criteria, that is hyperandrogenism and ovarian dysfunction and or PCOM. Now 2012 NIH extension of the ESHRE ASRM criteria, what it says is two of the three criteria required, and identification of specific phenotypes also included, that is hyperandrogenism, ovarian dysfunction, and PCO morphology in ultrasound. And phenotypes, like it's been divided into A, B, C, D. The phenotype A, it's mainly hyperandrogenism, ovarian dysfunction, and PCO morphology, all three present. B, hyperandrogenism, ovarian dysfunction. C, hyperandrogenism and polycystic ovarian morphology. D is ovarian dysfunction with polycystic ovarian morphology. This is how we diagnose the PCOD. So adult diagnostic criteria, that is Rotterdam, adolescent diagnostic criteria, these are all well defined in the books. So PCOS, a diagnosis of exclusion, that is clinical, biochemical, and ultrasound. The clinical criteria is hyperandrogenism, which can be presented like either hirsutism, acne, male pattern, balding, alopecia, or menstrual, they might complain with the menstrual irregularities. There can be fertility, subfertility, or infertility issues, obesity, and acanthosis nigricans. Biochemical, that is hyperandrogenemia, altered gonadotrophin ratios, that is already we described, increased LH-FSH ratio, increased AMH levels, there will be increased insulin resistance, and dyslipidemia. So ultrasound shows, that is follicular number per ovary. As I already mentioned, more than 15 follicles per ovary, that is PCOM, polycystic ovarian morphology, or ovarian volume more than 10 cc, and stromal thickness also. We can make out there is more ovarian stromal component. So ovulatory dysfunction, that is, they can present like cycle length more than 35 days. The normal cycle length is between 21 to 35 days. If the cycle length is more than 35 days associated with anovulatory cycles, if the cycle is 32 to 35 days, ovulation should be assessed. Measurement of serum progesterone in the mid-luteal phase should be done. If it is more than 2.5 nanograms, then it is the evidence for ovulation. If it is more than 7 nanograms, then it's like a regular luteal function. If sum of 3 consecutive serum values is more than 15 nanograms, it shows that the ovulation is occurring. So 10 to 15% of hyperandrogenic women with apparently normal cycles, they are anovulatory. Though they have regular cycles, they might be, actually ovulation might not be occurring in these patients. It means so. So this is how it looks. So normal ovary, how it looks, see, and PCO ovary, how it looks. So many follicles in one view. So there will be increased LH and decreased FSH, as I already mentioned, and more than 75% of the PCOD patients present with dysregulation in gonadotrophic function. Lean PCOD people, they might be increased LH pulse amplitude. So clinical and endocrinological characteristics of the main PCOD phenotypes. The hyperandrogenism, that is, there will be elevated circulating androgen levels, that is 60 to 80% of the PCOD patients. Which androgens to be measured will be having, whether to measure, we'll be thinking whether to measure total testosterone free or androstenedione or androstenedione sulfate, like that. So we can measure like mainly total testosterone, free testosterone, androstenedione, DHEAS or 17-hydroxy progesterone. Which one to be measured? The serum androgens, testosterone, total testosterone more commonly measured, but it's of limited value. So free testosterone most sensitive and only as adjuvant for diagnosis of hyperandrogenism disorders, not in lieu of clinical examination. Androstenedione, not much of a value. It increases the detection rate by only 10%. DHEAS, it's a weak androgen. It is from the adrenals, limiting the testing value, and 25% of the patients with PCOS, they might have supranormal levels. So sole elevation occurs only in 5 to 10%. 17-hydroxyprogesterone, there will be exaggerated response in PCOD patients after administration of GnRH agonist. So screening in its mainstay in screening the congenital adrenal hyperplasia, not in PCOD. So we have to measure mainly the free testosterone, which is the most sensitive indicator. So 2018 ESHRE says tests which should be used for biochemical hyperandrogenism is calculated free testosterone, free androgen index, calculated bioavailable testosterone. If total or free testosterone not elevated, then androstenedione and DHEAS could be considered. So limitations in androgen measurement, multiple androgens, many not considered, wide variability in normal population, and age and BMI not considered while establishing the normative values, androgens suppressed more rapidly by hormonal suppression than other clinical features. So it might give a false impression also. So metabolic evaluation will be done by measurement of waist circumference and BMI, complete lipid profile, including the total cholesterol, LDL, non-high density lipoproteins like cholesterol, HDL cholesterol, and triglycerides, and 2-hour post 75-gram oral glucose challenge test, that is OGCT, to assess the glucose tolerance. So exclusion of other disorders. We have to always exclude other disorders before branding them with a PCOS. Like ovarian, what are the causes for hyperandrogenism? Not only PCOS, there are other causes also, like Sertoli Leydig cell tumors, Hylas cell tumor, lipoid cell tumor, or hypertrichosis, that is luteoma of the pregnancy. All these also can cause hyperandrogenism. So adrenal causes include adrenal hyperplasia. It can be congenital or late onset, Cushing syndrome, adrenal tumors, and insulin resistance and androgen excess in obesity, or Hayran syndrome. And exogenous drug therapy also can mimic hyperandrogenism, like if people are taking androgens for any bodybuilding or muscle building, like that, like androgens, anabolics, oral contraceptives, synthetic progestrogens, danazole, phenytoin, diazoxide, cortisone, any of these drugs, if they are taking for some or the other treatment, then also it can give a picture of hyperandrogenism. So post-menopausal also, there will be hyperandrogenism. Mainly the source will be from the adrenals, not the ovary. And pituitary tumors also, like hormone secreting tumors like Cushing's disease, in case of acromegaly or idiopathic, increased sensitivity to androgens. There will be normal androgens only, but the patient will be, they have an increased sensitivity. So these differential diagnosis can mimic hyperandrogenism, not only PCO patients. What to do? How to treat these patients? And this is the commonest problem. If we sit in the infertility OPD, if 10 patients we see per day, almost 6 to 7 patients daily will be PCO patients. So how to treat them? Management is through lifestyle modifications, management of insulin resistance, management of PCOD in infertility, and management of other things like hirsutism, acne, menstrual irregularities. So these things we have to manage stepwise. So lifestyle modifications. So what should we do? One thing, by diet and increasing the physical activity, restricting the food, increasing the physical activity. Thereby weight gain, thereby we can manage our weight and the complaints will come down. So when the androgens will come down, automatically their cycles also will become irregular. So calorie restriction, increasing the physical activity, and behavioral modification. That is more of physical activity, more like sedentary. We should come out of the sedentary lifestyle. So behavioral intervention means lifestyle interventions could include behavioral strategies such as goal setting, self-monitoring, stimulus control, problem solving, assertiveness training, slower eating, reinforcing the changes, and relapse prevention. To optimize the weight management, healthy lifestyle, and emotional well-being in women with PCOS is very much required. So a reduction in 5 to 10% of the body weight over 6 months. So it re-establishes the ovarian function in more than 50% of the obese PCOS. That's what I keep saying. If that weight losing tendency starts, most of the hormones will get regularized and they start naturally, many of them will conceive because of the weight management. So there will be diet and lifestyle modifications with the help of pharmacological agents or bariatric surgery. Weight reduction can be planned. Depending upon their BMI, they should be planned. The dietary goal should be consumption of monosaturated fats, low carb diet, more of vitamin supplementation, food rich in calcium and vitamin D, zinc supplementation, decreased ratio of omega-6 and omega-3 fatty acids, reduce the calorie intake, saturated fats, cholesterol, and high glycemic index foods. So these should be planned in the diet based on the diet advice, dietitian's advice. Nutrition guidelines is balanced carbohydrate intake around 1400 kilocalories per day. Do not skip the meals. So fasting is not going to help. So it is only minimalizing the diet. It mainly improving the quality and decreasing the quantity of the food will help instead of skipping the meals. So gradually increase the high fiber content in the diet, like whole grain bread, oats, barley, corn, like that. Emphasize on lean protein foods like fish and egg whites. Consume 25 to 30% of the calories as fat, that is omega-3 fatty acids in new form. Include 2 to 3 feeds of low-fat dairy products per day, that is 1% milk or yogurt. Include phytonutrients like spinach, carrot, and yam. Control portions and limit the foods containing trans fatty acids. So adults exercise, what is recommended is between 18 to 64 years, 150 minutes per week of moderate intensity physical activity or 75 minutes per week of vigorous intensity or an equivalent combination of both, including muscle strengthening activities or 2 non-consecutive days per week. And for adolescents, it is 60 minutes moderate to vigorous intensity physical activity per day, including those that strengthen the muscle and bone at least 3 times weekly. And for activity, at least 10 minutes, bouts are around 1000 steps aiming to achieve at least 30 minutes daily on most of the days is necessary in exercise. Pharmacological agents, like how they help, like statins or metformins, that is peripherally increasing the insulin sensitization or insulin consumption. So anti-obesity medications, in addition to lifestyle, could be considered for the management of obesity in adults with PCOS after lifestyle intervention as per general population recommendations. For anti-obesity medications, cost, contraindications, side effects, variable availability, and regulatory status need to be considered, and pregnancy needs to be avoided while taking these medications. They can be hazardous for pregnancy. So coming to bariatric surgeries, three most common bariatric surgeries what we use is either gastric bypass or sleeve gastrectomy or an adjustable gastric band. This is recommended only if the BMI is more than 30 kg per meter square, not for everyone else. So there will be, with this, the key features of PCO and improvement seen after the bariatric surgery is there will be decrease in androgens, there will be decreased in SHBG and decreased in hirsutism also. In metabolic component, there will be decrease in insulin resistance, in decrease in diabetes and gestational diabetes, and decrease in hypertension. Coming to the ovulation component, restoration of the menstrual function, improved ovulation and spontaneous pregnancy rates have been noted after the bariatric surgeries. There will be lower BMI, decreased leptin levels, and improved self-image and quality of the life. So management of insulin resistance by using the insulin sensitizing agents like metformin or thiazolidinediones, inositols or acordose can help in managing the insulin resistance. So how does metformin PCOS help? It increases the insulin sensitivity. It reduces the serum levels of insulin and androgens. It reduces the hirsutism, improves the ovulation rates thereby, and it decreases the OHS's risk even if they are going for IVF or any other treatment, and it improves the pregnancy rates. So strategies for the use of insulin sensitizing drugs as per the journal in 20. So to treat the infertility in women with PCO, it confirms the renal and liver function. There will be impaired GTT and frank diabetes. So we start the metformin OD for 4 days. They will be gradually increasing the dose till their tolerance level. So minoxidil and D-chiro-inositol also will help. That is two main stereoisomers of the metformin. They are involved in calcium metabolism, and they help in oocyte development and final oocyte maturation also. So inositol in any form should currently be considered in experimental therapy with emerging evidence on efficacy, highlighting the need for further research. So ovulation induction, these people are coming for fertility issues. So ovulation induction, how we are going to do? We can use either oral pharmacological agents for ovulation induction like SERMs or gonadotrophins we can use, or third line will be IVF. Either we can go for ovulation induction with the clomiphene citrate or letrozole, or we can go for gonadotrophin injections followed by timed intercourse or the IUI, or we can go for IVF directly. See, clomiphene citrate and letrozole. So how long should we continue the clomiphene citrate? Means treatment should be limited to 6 ovulatory cycles. If we are trying ovulation induction, maximum 6 ovulatory cycles. Cumulative live birth rates vary from 50 to 60% up to 6 cycles. So treatment options for CC resistance, that we can use either extended CC, we can add on with the insulin sensitizers like metformin, minoxidil, addition of steroids, pre-treatment with the OCPs, or adding antioxidants and other adjuvants like vitamin D, or adding gonadotrophins might improve this CC resistance. So how do glucocorticoids, that is steroids, help? It reduces the adrenal androgen secretion, thereby 40% lower the peripheral androgens. It increases FSH synthesis and secretion. It improves the clomiphene citrate responsiveness. It acts indirectly by increasing the serum growth hormone, insulin-like growth factors, and follicular fluid insulin-like growth factor concentrations. So clomiphene citrate and dexamethasone treatment along with the steroid, there will be higher ovulation and pregnancy rates. if we add dexamethasone along with the CC, that is dexamethasone 2 milligrams should be added from day 3 to day 12, 10 days. So pre-treatment with OCPs can also be tried. That is, if a few months followed by CC results, then OCPs prevent the ovulation by reducing the GnRH secretion, reduces the pituitary responsiveness to GnRH, and it reduces the FSH-LH. It improves the androgenic ovarian microenvironment. So N-acetylcysteine, this also acts like an adjunctive and it improves the ovulation rates. All this vitamin D adding at least 1,000 to 2,000 units per day or 60,000 units per week will definitely improve the ovulation rates along with the ovulogens. Not only them, along with the ovulogens. So aromatase inhibitors like letrozole also will act like CC. It appears to improve the live birth and pregnancy rates compared to clomiphene citrate when used to cause ovulation and timed intercourse. No difference in miscarriage rate or multiple pregnancy rate compared to CC, and no difference between letrozole and laparoscopic ovarian drilling for any observed outcomes, although there were few relevant studies. That is, we can either first line pharmacological, either we can go for letrozole, clomiphene citrate plus metformin and gonadotrophins. We can add adjuvants like steroids, vitamin D supplements, other things. Second line treatment will be gonadotrophins and luteal phase management. That is gonadotrophins, second line pharmacological agents in PCOS who have failed first line oral ovulation induction therapy and are anovulatory and infertile with no other infertility factors. So gonadotrophin induced ovulation should only be triggered when there are fewer than 3 mature follicles and should be cancelled if there are more than 2 mature follicles, with the patient advised to avoid unprotected intercourse to minimize the complications of OHSS. That is the main complication associated with the usage of gonadotrophins. So gonadotrophin stimulation regimens, it can be chronic low dose, step-up gonadotrophin regimen, step-down or sequential protocol. So gonadotrophin ovarian stimulation is used in 3 different categories: women with WHO group 2 anovulation, that is PCOS, or group 1, that is hypogonadotrophic hypogonadism, or ovulatory women undergoing IUI for unexplained or mild male factor infertility. In these category of patients, we can use gonadotrophins for ovulation or for stimulation. The conventional regimen will start with a low dose, either 75 or 150, monitor regularly. Our aim is to maximum 2 or 3 follicles only till trigger time. If the follicle reaches more than 16, then we give the trigger. So starting dose can be we start either day 2 or day 3 of the cycle. So gonadotrophin low dose step-up protocol, here we'll start with a minimum dose of 50 to 75 for 14 days continuously, then do a scan, reassess, then adjust, that is increase the dose with 25 or 37.5, like that only. Keep increasing every week with the monitoring. See the follicular growth and then till trigger plus 37.5, like that we keep adding. It is a chronic low dose step-up protocol. High rates of monofollicular ovulation advantages, lesser multiple pregnancies, lesser OHSS, good pregnancy rates. Disadvantage is long duration. They have to go through for 3 to 4 weeks. Gonadotrophin low dose step down protocol. Here we start with a higher dose like 150. Then gradually we'll decrease the dose depending upon the response. So advantages is it reduces the duration. Disadvantages, cycle cancellation might be high because of the more number of follicular developments. So sequential protocol, that is initially step up and then followed by step down. So what are the differences? A comparative study, step up and step down. So in step up protocol, monofollicular development is high. Hyperstimulation rates are less. Ovulation rates are also high. In step down, the follicular developments are high and cycle cancellations are also high. Hyperstimulation rates are also high. Ovulation rates are less compared to the step up protocol. So indications is anovulatory CC, LOD indications, anovulatory CC resistant patients, young women, high LH, and that is laparoscopic ovarian drilling indications. So anovulatory CC resistant, young women, high LH and high AMH, exaggerated response to gonadotrophins in previous cycles, that is going for OHSS and then cancelling cycles. So in these patients, we can go for laparoscopic ovarian drilling. and non-compliance or non-feasibility with the frequent intensive monitoring. So mechanism, destruction of the ovarian theca and stroma, it reduces the ovarian androgens, thereby reduces the follicular atresia, reduces the LH hyperstimulation, temporarily fall in inhibin B, moderate rise in FSH and SHBG, thereby restores the ovulation. This is the mechanism involved in laparoscopic ovarian drilling. So it should be a second-line therapy for women with PCOS who are clomiphene citrate resistant with anovulatory infertility and no other infertility factors. So laparoscopic ovarian surgery could potentially be offered as first-line treatment if laparoscopy is indicated for another reason in women with PCOS with anovulatory infertility and no other infertility factors. So it could be predicted to result in poor reproductive outcome in women with CC-resistant PCOS when they are obese, long duration of infertility more than 3 years, and basal LH levels are less than 10, marked biochemical hyperandrogenism, or high basal AMH levels of more than or equal to 7. So IVF or ICSI, that is CC resistance, failed ovarian drilling or gonadotropin therapy, there are associated tubal factors, associated other pathogenesis like endometriosis, severe male factor, then we can directly go for ART, that is IVF or ICSI. So principles are third line where other ovulation induction therapies have failed, and GnRH antagonist protocol should be followed. Elective freeze-all embryos should be done because of there will be more oocyte retrieval, higher hormonal milieu in these patients. OHS's risk is high, that's why. So IVM, in vitro maturation, in cases of PCOS planning to undergo IVF ICSI where there is chance of OHSs, then we can go for IVF. Here oocytes collected from smaller antral follicles before the spontaneous ovulation, and these oocytes will be matured in vitro in the lab followed by routine IVF ICSI or an embryo transfer. So avoidance of the side effects that is resulting from the gonadotropin stimulation, including the risk of OHSs, reduced cost, simplified treatment, and there will be less discomfort for the patients. So these are my references for the today's presentation. Thank you all. Any doubts?
Thank you, ma'am. Your passion for the topic really came through in your words. We are grateful for the knowledge and you shared with us. Thank you.